Hello and welcome to Spinal Chat Episode 3. My name is Dr. Ivan Stoev and I am a board-certified neurosurgeon practicing in Nashville, Tennessee. Today's topic will be on the cervical spine. We're going to discuss cervical disc herniations, the anterior cervical discectomy and fusion procedure that we do for that, and some other conditions of the cervical spine. So thank you again for tuning in, and I appreciate all the comments and questions from the previous episodes. The cervical spine is unique in its ability to produce a greater range of motion than any other part of the spine. Because of that, because of this demand on it, there is degenerative changes that occur throughout life. These degenerative changes can include the joints in the back of the spine, which are called facet joints, or the discs in the front, which can lead to a degenerative disc disease and various degrees of herniations and stenosis. Now, a herniated disc can manifest in many different ways, depending on the size of it, the location of it, and the number of discs that are herniated. The simplest form of that would be a small disc herniation that is compressing a nerve. Any one of these little nerves that are exiting the spine can be affected. And the symptoms manifest as radiculopathy. Radiculopathy means irritation, mechanical compression of a nerve that goes to the arm. And different nerves go to different parts of the arm. That can lead to complaints such as numbness, tingling, burning, pain, or even weakness of an extremity. A most serious condition would be a spinal cord compression. Now that can occur chronically from a condition called spinal stenosis, which is basically narrowing of the canal where the spinal cord is. Myelopathy is a very serious and dangerous thing because it leads to damage to the spinal cord. And the spinal cord does not have a great ability to heal and repair. So once a damage is there, it oftentimes is irreversible. So as neurosurgeons, we're very concerned to avoid and prevent that from happening in patients who are prone to get that. So myelopathy can present with poor coordination, loss of sensation in the extremities, numbness and weakness, difficulty walking, difficulty with fine motor control, such as buttoning a shirt or tying a tie or tying your shoelaces. If this is a process that has been occurring for a long time, such as degenerative changes in the spine that lead to spinal stenosis, oftentimes the onset of the symptoms is very slow and gradual, and people don't get alarmed by that. And it is interesting because I've seen patients like that in my office who are severely disabled and they have contractures of their extremities and they have very little function of their extremities. And when I ask them how come it got so bad and how did they just let it get to that level, oftentimes they say that, well, it started off with dropping things and just a little bit of numbness and tingling and gradually progressed to a level where now they're disabled. So myelopathy and spinal cord compression are very, very serious, and we take that very seriously. If there is evidence of that, we don't waste time with conservative therapy. This is an indication to have surgery. So the spinal cord compression can occur from an acute disc herniation, which is a sudden event, maybe due to trauma or accident or something like that, where a disc herniates and it compresses the spinal cord. When we see something like that, we immediately take the patient to surgery to prevent any further damage to the spinal cord and decompress the spinal canal. In cases where this is a chronic ongoing thing, due to degeneration, due to thickening of ligaments and some other reasons that can cause narrowing of the canal, then we also do surgery, but it's not an emergent procedure as when you have an acute disc herniation. Now we can do different procedures in the spine, and we can go from the front of the neck and remove discs that way and put a titanium plate and screws. We can also go from the back of the neck by opening the spinal canal, by removing some of the bone here in the back and placing screws and rods as well. Now, how do we decide which surgery we perform? Well, that depends on a lot of things. First, it depends on the shape of the neck. It also depends on the degree of disc herniations. It depends on how many discs are involved. And the overall shape and also some of the other anatomy there, such as the ligaments, if they're thick, if there's compression from the back or the front. So there are a lot of things that factor into that decision. Today, we're going to talk about the anterior cervical discectomy and fusion procedure. Here we have a model of the cervical spine. This is the front of the spine, so your throat is here in the front. This is the back of the spine, and this here is just a portion of your skull, so the head is here in the top. In the front, we have discs between the vertebrae, and these discs are like little cushions. They're like little shock absorbers. They support the weight of your head and some of the neck muscles that are attaching to the neck. And they also provide some flexibility for the spine. Now in the back, we have these facet joints. These little slits are actually joints that connect the vertebrae together and allow your spine to move. These yellow things are the nerves that exit from the spine through small openings between the vertebrae called neuroforamina. These nerves go to different parts of the arms and provide sensation and movement and strength to the extremities. In the central part here, we have the central canal where the spinal cord resides. And from the spinal cord, these nerves exit to go to the arms. When you have a disc herniation compressing a nerve or compressing the spinal cord, we do a procedure called anterior cervical discectomy and fusion. We make an incision in the front of the neck, we cut the skin, and then we move all the tissues out of the way to go to the front of the spine. Once we're here in the front, we cut off the discs that are diseased, and we replace them with little grafts. They can be made of different material, such as they can be a donor bone graft, they can be made out of titanium, they can be made out of a PEEK material, which is polyethylketone material that is packed with bone. It's basically a hollow ring that allows for your body to create a bone bridge between the vertebrae and fuse them into one solid piece. Now here's another model of the cervical spine. So this is the front here, and once we remove the discs, we put the grafts in, and you can barely see them here, but they basically support the weight of the neck and provide alignment and a natural weight distribution here in the neck, as well as we placed a small titanium plate with titanium screws to hold everything together. Now eventually, you're going to fuse these bones together into one, but until that happens, the plate and the screws provide support for the spine. This is a procedure that we have been doing for a long time. It has a very high success rate, but there are some downsides to it, and you're going to lose some mobility when you have a fusion. It is about 8 degrees of flexion extension per level. For 1 and 2 levels, it doesn't make a lot of difference, and most people don't really notice a big change. However, the more levels you fuse, the more mobility you're going to lose. Mobility, however, is not the major downside to this surgery. The major downside is something called adjacent level disease. And this means that if you fuse a part of the spine, the rest of it has to take up that slack a little bit more. So that puts the disc above and the disc below at a disadvantage. It basically increases the wear and tear of those discs, and that can lead to a degeneration here that may cause a problem in the future. That degree or that rate of degeneration is about 2.8% per year. A small number, however, it tends to magnify over many years. So this is the major really downside to having a fusion. It's the adjacent level disease and the possibility of needing further surgery for those levels. For that reason, we have come up with a different approach, and this is an artificial disc placement. An artificial disc is just one of many different types, but it's made out of titanium, and it basically allows for the spine to preserve its mobility in all degrees and all range of motion that it originally had. So because it's made out of titanium, it does not wear out, and it also protects the level above and the level below from that degeneration. I'm going to talk about the artificial discs in a separate video because there are reasons why you could get it and you couldn't get it, and we're going to get into that later. So here's a model of the cervical spine. This is the front, and this is the back, and this is just a part of the skull that is here on the top. The normal shape of the cervical spine is like the letter C. It is supposed to curve back. Now this model is not very good because it's kind of going straight, but normally the curvature is like the letter C. And this is very important. So in cases where you lose some of that curvature, or you have more like of this scenario where the spine is going straight up or even going the wrong way, curving forward, the best way to restore some of that configuration of a normal spine is to go from the front. And this is when we're going to do the anterior cervical discectomy and fusion procedure by replacing the discs here with little grafts and allowing us to bring the neck into a more natural position. This is going to maintain the normal natural balance of the human body, and it will also allow us to let the spinal cord drift back into the spinal canal and relieve the compression from the front. So in cases where the spinal shape has been preserved in the letter C, we can also go from the back and do a procedure from there, and I'm going to have a video on that in the future, so we're going to talk about that later. So not everybody needs to have surgery on their cervical spine if they have a herniated disc. And it's important to understand that when you have a small disc herniation that is irritating a nerve root, but it's not causing a severe compression of the nerve or compression of the spinal cord, then we try to do conservative management first. One of the things that can be very helpful is something called cervical spine traction. The cervical spine traction can be done at home, and there are a couple of varieties of it. One is to place an inflatable collar in your neck. There's a little pump associated with it, and it basically expands and allows the neck to stretch. Another way to do that is to actually have a little chin strap that is connected to a pulley system that you can put on any door, over any door, and there's a counterweight, usually water, that provides that force of distracting or pulling up of the cervical spine. These distracting forces can stretch the discs. They can create a little bit of a negative pressure inside the discs and allow for these herniations to get reduced a little bit over time, or in essence get sucked back in. It's a very effective way, and it works in the majority of patients, but it's good for small discs that are not causing any spinal cord damage. In addition to that, some things can be done that can quickly and rapidly resolve the symptoms of pain, and those are cervical epidural steroid injections. This is done by pain management specialists. They inject a concentrated form of a steroid or anti-inflammatory medicine into the cervical spine. This reaches a very high concentration at the target area. Now, they're much more effective than taking pills by mouth, because when you take a medicine by mouth, it has to go through the whole body before it gets to the area of interest. So you can't really reach a very highly concentrated form when you take it by mouth. An epidural injection delivers that medicine directly where the source of the pain is, and it has a pretty good effect, and oftentimes it's a lasting effect of pain relief. This by itself doesn't really fix the cervical spine. It's just really a symptomatic control, and it's just designed to lower the amount of pain that you experience, but it doesn't actually repair the disc or do anything physiologically or anatomically important in that area. So it's not a treatment by itself. It's just to bridge, it's a bridging therapy while you're doing the cervical traction and some of the other things. There are also TENS units, which is transcutaneous electrical stimulation, that can help with the pain. There's acupuncture, there's skin patches, and a variety of other oral medications that can be helpful. So, for patients who have mild radiculopathy or mild irritation of a single nerve root, this is the therapy that we prefer to use in the very beginning. It is effective for most patients, and if it's not, then the next step will be surgical discussion. For patients who have spinal cord compression or symptoms of myelopathy, conservative management is out of the window at that point. Surgery is indicated, and on an urgent basis, because we're trying to prevent spinal cord injury and damage. And the only way to do that is to relieve the compression of the spinal cord. So we don't wait any period of time of stretching and all these other things that we talked about. The approach that surgeons use varies on the location of the herniation, on the anatomy of the patient, and there are a lot of other factors involved as well. And we're going to cover some of the other approaches in future lecture series, but today we're just going to stick to the anterior cervical discectomy infusion. So, as always, your questions and comments are very welcome, and I appreciate your time, and I appreciate you sharing and subscribing to my channel. Please stay tuned in for future videos. I'm going to try to do this on a weekly basis, and I'm going to try to answer any questions that you may have, and feel free to post them on my channel in the discussion section. Thank you so much for sharing your time with me.